Okay, thank you, Sri Priya. Am I audible?
Yes, sir, you are.
Okay, so very happy to be here today with you. So how many registrations we have? We can see 45 participants have joined, and how many more are we expecting?
Sir, the total count shared by NHM Haryana is 100 plus CHOs, and we have 80 plus registrations in our IECO LMS. So maybe a couple of more to join.
Okay, we expect that others will also join sometime. Okay, let me share the presentation. So before moving on to the session as such, I would request all of you to please comment. This should be an interactive session. So I would request you to unmute and speak whenever there is a question, or you can even give your comments in the chat. Okay. So we are going to talk about pain and palliative care today. So we will start with a photo of a patient. So can anybody tell me what is the problem with this young girl? You can unmute and speak, or just give your comments in the chat box. Please, please look at this photo of this patient and tell me what you are seeing.
A malignant tumor.
Okay, where?
Sir, it seems like a tumor.
Okay. Anybody else? Are there any more problems? Okay, I hope you can see this swelling on the left shoulder of this girl. Okay, so talking about the history, let's say 8-year-old girl who, when she was studying in 4th standard, she had a small swelling on the left shoulder, but it suddenly increased in size, and during this time they were undergoing various investigation to understand what is the diagnosis. So they have been going from hospitals to hospitals, and at last she was diagnosed with osteosarcoma of left humerus, which is a type of cancer affecting the bones. Okay, so she again got investigated at many hospitals, and the hospitals where she went, they told that as of now the cancer has advanced, and probably they will not be able to do anything. So the parents were not satisfied, and they took this girl to many big hospitals. And what they suggested was disarticulation of the left upper limb. And the parents wanted to know what would be the prognosis like. So they told them that this is just this will not cure the disease, but this might give some relief for the pain or something like that. But it is not going to cause or it will not prolong her life. And even if disarticulate, that will not guarantee that she will not have any problem. Okay. So if this is the case, how many of you would like this girl to undergo disarticulation of the left upper limb? Can I have your comments in the chat box? Yes or no? Suppose this is a she's one of your relative or somebody. So if she is in such a condition, and the doctor says, no, we cannot do anything. We can do disarticulation if you want, but that is not going to cure the disease. So how do you go? Would you like to go with the disarticulation, or would you like not to choose disarticulation? Okay, I can see there are two comments. Dr. Preeti Yadav, Dr. Najish Kumar, Dr. Bharat, Dr. Pankaj. So anybody else has any other opinion who says no, I don't want this girl to undergo disarticulation? So can I ask any of you who has given yes as comment, why would you like or why do you want this patient to undergo disarticulation? What would be the benefit for this patient by undergoing disarticulation? You can unmute and speak.
Sir, because जो focus of neoplasm
So Dr. Pankaj, yeah, please.
yes sir, hello.
So
Yes sir.
you want to remove the focus of neoplasm, is that what you are telling?
Yes sir.
Okay, thank you, Dr. Pankaj. To get a relief of pain, that's by Dr. Preeti. Okay. But you have to also understand that even if you remove this tumor, it is not going to prolong the life of this girl, because that is already advanced. So just removing the tumor just to remove the malignancy, that is not going to be beneficial for the patient, isn't it? No, malignancy will not stop. Please don't think that when there is a malignancy, that is restricted to that site itself, especially when the malignancy is advanced, because there would be small deposits at the distant parts of the body, which is known as metastasis. Okay. So this patient already has an advanced disease. So even if you remove the shoulder or the left upper limb, the malignancy has already spread to other parts of the body.
But
Yeah.
sir, major of her illness like swelling, excessive disorientation of localized structures, pressure over pain over structures would reduce, I think.
Okay, so this is going to be a major surgery. Should we look and understand that there are a lot of risks also involved when you do surgery for these patients, and we have to see whether there are any other methods by which we can reduce these problems, like pain or something else. Okay, I'm just moving forward. So what I want to tell you, the parents, they took a decision that they are not going to, they don't want this their child to undergo disarticulation. Just think of ourselves. How many of us would like to, or how many of us would can bear when we lose one of our limb, or for that matter, even a finger, if if we get into some accident and one of our finger got injury, and the doctor says you have to remove that finger because it is not vital, then what would be our feeling? So just think of that also when we say that, okay, we would, okay, if it is beneficial or if it is absolutely necessary, then it is okay to undergo that procedure. But when the doctor himself says, okay, disarticulation can be done, but that is not going to affect the course of the tumor. It will not do any benefit for the patient. Is somebody speaking?
No, sir. I think that was unmuted by mistake. You may continue.
Okay. So if there is no benefit with a treatment, when you do treatment, there are both benefits and risk. So if the benefit is more than risk, then you can do that procedure. But if the risk or complications are more, it is better, or you have to avoid that procedure. Okay. So what about the family of this child? She has a father and mother. Both are manual laborers, and but the problem is that they are living separately. Uh, this is because the father is alcoholic, and he comes every day to the home after taking alcohol, and a big fight between the mother and father. So this is happening happening most of the days. So that's why they are living separately. And to add to this problem, this girl has a child. Girl has a brother who has learning disability. So that's another problem. And they also do not have money because both are manual laborers, and they have been taking this child from hospital to hospital, and now they are financially drained. Okay. And what are the problems now? She attends the clinic. So you can see this child, how she is sitting. You can see she is holding her hand on the other hand because she is in severe pain, and she can keep the upper limb only in this position. And if she moves, and also she can sit only like this. So that's that's another problem. And whenever somebody comes near her, she starts crying because she thinks they will touch her, and that will increase the pain. So you can see she's unable to sleep because of this pain, and she has not slept properly for the past 1 or 2 months because of severe pain. And also you can see this bed sheets with some blood stains. Okay. So that is because you can see this, there is a small ulcer here. From this, there is bleeding coming in. So coming out. So she has severe pain, and she is unable to sleep because of pain. And in addition, there is bleeding also. So she attended many hospitals, as I told previously. She has taken many analgesic, but there is no relief for her pain. So let me pause here for a minute and ask you, what are the suffering faced by this a young girl. Anybody please tell? What are the sufferings faced by this patient? Okay, I can see one comment, neural pain. Please unmute and speak.
Pain,
Yeah,
pain, swelling, local wound, discomfort in moving her hand and doing daily routine work.
okay. Yeah, pain, agony of a terminal illness. Then mentally disturbed, mental disturbance, physical, mental, social pain. Am I not audible? I see there is a comment, voice not audible. Sripriya?
No, sir, audible, sir.
You are audible only, sir. You are clear.
Okay. Okay, any other problems? Psychological problems, okay. So why she has psychological problems?
Assuming, sir, myself, Dr. Devish, because the patient is not doing his or her is routine activity easily, then she is going in depression
Okay,
or
thank
she
you.
is feeling depressed.
Yeah, thank you. Unable to even eat, proper sleeping, yeah. Because of sleeping problem, social withdrawal, loneliness, anxiety, pain affect mental health. Yeah, all these are very good answers. Okay. So
Mainly, it will affect her daily routine activities.
okay, yeah, that's right. If there is severe pain, it can affect the patient in lot of ways, isn't it? It is not only going to affect sleep, and if you don't sleep, next day you will be angry, anxious. You will not be able to take food. There are many problems. But in addition to that, there are many other problems. As you told, this girl has physical problems in the form of severe pain, breathlessness, sleeplessness, bleeding from the side, and she has psychological problems. And one of the major source of psychological problem would be that um, her father is abusing the mother, and he's an alcoholic, and they are living separately. But this girl liked the father very much, and she, as of now, stays with her mother. So these all are causes of psychological stress, and socially and definitely, because she's unable to go out because she was studying in fourth standard, and she's unable to see any of her friends, and she's unable to move. She's in a room, so she's socially isolated. And probably there is something called spiritual pain also. And she thinks, why God gave this me? I am a young girl and I have not done any sin, but still this happened to me. So this is called a spiritual factor. So before moving on to all the other aspects, I would like you to tell me what you mean, what is meant by pain? What is the definition of pain? Can anybody tell me what is the definition? Okay, So international ISP means International Association for Study of Pain. So this is the definition. Pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damages. That means pain is an unpleasant sensation, isn't it? Pain is never going to be pleasant for any of us. So pain is definitely an unpleasant sensation, but it's also an emotional experience. That means emotions can actually modulate pain, or emotions can affect pain. Suppose you are very happy and you somehow had an injury. That's suppose that is one situation, and another situation, you are mentally depressed, you are very sad, and you also had an injury on the same place with the same depth and things like that. So these are the two situations. Do you think any of this situation, the patient or you will have more pain or less pain? What do you think?
Yes, we will feel more pain when we are not happy.
Sorry, it's not very.
Sir, more pain.
We will
Yeah.
we will feel more pain when we are not happy.
Yeah. So when you are sad, that can actually influence the manifestation of pain, and it can increase the pain if you are sad. But if you are happy, the pain can be less. So that's what emotions can actually affect pain. So it is very important to find out the emotional aspect of the patient also when you assess for pain. Okay. And it is associated with actual tissue damage. That whenever we have an injury, suppose it is with a knife, there is an injury. So there is tissue damage. So that tissue damage produces injury. But it continues to say, or potential tissue damage. What is potential tissue damage? Potential tissue damage means there is a stimulus now, but that is not causing tissue damage now. But if this stimulus prolongs, it can cause tissue injury. So that is known as potential tissue damage. For example, suppose we take angina. You know what is angina? Anybody? Do you know what is myocardial infarction or heart attack?
It's a chest pain caused
Sorry?
by reduced blood flow. It's a type of a chest pain caused by reduced blood flow.
Yeah, thank you, Dr. Pradeep. Pradeep Kaur. Yeah. So angina means it is a momentary reduction in blood flow in the heart that will cause chest pain. But after some time, after a few seconds, it will be normal. So it is a momentary reduction in blood flow. This is not going to cause any injury to the myocardium. Okay, it is not going to cause any injury to the muscular layer of the heart, which helps in pumping of blood. But when this, suppose this angina is going to be sustained for a few minutes, what can happen? Anybody?
Then I think a myocardial infarction.
Yeah, it can cause myocardial infarction. That means there is a stimulus in form of reduced blood flow, but that is momentary. But that is not causing any injury to the muscular layer of the heart as of now. But this blood flow, if it gets prolonged, if the blood flow reduced for a longer period of time, then it will lead to myocardial infarction, that is tissue injury. So that's what is known as potential tissue damage, a stimulus which is not causing any injury to the tissue as of now. But if this stimulus gets prolonged, then it will cause damage. Okay. And it continues to say that or described in terms of such damages. That means suppose a patient comes to you and tell you that I have severe pain on the left upper limb. It was there for 4 years. It is burning type of pain. And you investigate, you took history, you did examination, you did all the investigation, but you couldn't find out anything that is contributing to pain. Then what would you do? What would you do? A patient came to you with left upper limb pain for the past 4 years. You took history, you did examination, and you did investigations, but you couldn't find out any reason for pain. Then what would you do usually?
Assurance to patient
Okay.
with morphine or other pathogen like injections, and to thrombolyze the patient.
Okay. So here what happens is most of the time this patient keeps coming to you, not only 2 or 3 times. He comes to you every once in every 2 weeks. And now it has been for the past 1 year, this patient has been coming to you saying pain, 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 pain. But there is nothing you can find out. So mostly what happens, people will think that, okay, this patient has some psychiatric problems. So let us refer to psychiatrist. Okay. But even if we are unable to find out any reason for pain, if a patient describes pain in such terms, we have to believe the patient. That's what here it is said, described. If somebody describes pain in such terms, then you have to believe the patient. So this is the most important thing in pain management and assessment. You have to believe the patient about his or her pain, even if you are unable to find out any reason for pain. Okay. And but this definition has been changed now, and you can see a little bit of change here. It's an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. So do you think all the people who have pain, will they describe about pain? Can all of the patients describe about pain?
No, sir.
No. So there are many patients who will not be able to describe about pain. Maybe newborns, people with diseases which affects the sound production, people with dementia, Alzheimer's disease at later stages. They will not be able to describe. They will not be able to communicate to us that they have pain. So that's why that is one of the reasons why the previous definition has changed to the second definition. So this is the newest definition. Okay, so I'm going to talk about little bit of physiology of pain. Can anybody identify what is this?
Sensory motor pathway.
Yeah, this is a section of spinal cord. Okay, so you can see there is a structure called dorsal root ganglion in the near to the spinal cord, and this dorsal root ganglion sends out one filament to the dorsal horn of spinal cord, which is known as afferent. Peripheral. There is one one which sends to dorsal horn, and the other which comes out to the peripheral tissues. So from the nearby spinal cord, the peripheral nerve. This is actually peripheral nerve. Okay. It has a central process and a peripheral process. Central process goes to the dorsal horn, and peripheral process comes to outside, and it supplies our skin, muscles, bones, tissues, etc. Okay. So this peripheral nerves ends in, you can see, it ends in free nerve endings. Please see this. It ends with so many nerve endings. This is known as nociceptor. Noci means pain. Septor means receptor. So pain receptor is known as nociceptor. Okay. This nociceptor is free nerve endings in our body. And see this, how pain is transmitted, or pain pathway. This is the pain pathway. You can see this is the free nerve endings, and from here, this is the peripheral nerve, which comes to the dorsal horn of spinal cord, and then it crosses to opposite side, and then it ascends as lateral spinothalamic tract, and it relays in thalamus, and from thalamus, it will goes to a somatosensory area of the cortex. Okay, so this is pain pathway. This is how pain from one point reaches our brain. Okay, and this process is known as nociception. Okay, nociception and pain are two different things. Nociception means it is the sorry, Dr. Manisha, are you saying something? Okay, and nociception and pain are two different things. Nociception means the formation of impulse at the site of injury, and or the formation of electricity, and its transmission, and when it reaches the somatosensory area of the cortex, that is known as nociception. It occurs at the level of nerves. But pain means pain has not only this component. Pain has so many components. Pain has, as I told you, it has a sensory component. It has our emotions can affect this nociception. So when all these components together forms pain. So nociception, it occurs at 4 stages, which are known as transduction, transmission, modulation, and perception. So what is transduction? So you can see here, there is an injury occurring here. And what happens at that site? There are a lot of chemical mediators released at this site. And these chemical mediators, you can see the names prostaglandins. So prostaglandins are one of the most important pain producing substance. Then substance B, potassium ions, bradykinin, hydrogen ions. So there are a lot of chemicals released at the site of the injury, which together known as inflammatory soup. Okay, inflammatory soup, SOUP, soup. So these chemicals, they stimulate the nerve endings. That is, they stimulate the nociceptors. We told that free nerve endings, which are known as nociceptors. So these chemicals, inflammatory mediators or inflammatory soup, stimulate the free nerve endings, and it produces an electricity at that site. I'm using simple terms rather than using medical terms. Okay. So actually it is polarization and repolarization. There are some medical words, but I'm using the word formation of an impulse. Sripriya?
Priyanka, kindly mute yourself. We are unable to mute you from our end. We would request everyone to please pay attention and keep your devices muted. You may
So,
continue.
So you can see this inflammatory soup, it stimulates the free nerve endings and it produces an electrical impulse at the site of injury, which is known as transduction. Okay. And please remember that in the inflammatory soup, prostaglandin are one of the most important chemical which produces pain. And what happens next? Next is transduction. So what happens in transduction? So the electrical impulse formed at the site of injury. Sorry, transduction. And now transduction we finished. Now we have next step is transmission. The electrical impulse formed at the site of the injury has to travel through peripheral nerve and then through lateral spinothalamic tract to the thalamus, and then it reaches the brain. So this is known as transmission of impulse from free nerve endings to the cortex. That is transmission. And next is modulation. So you know that pain is the pain impulse when they travel from the site of injury to the brain. The impulse can get modified. That is known as modulation. Okay. So what all are the ways by which modulation occurs? One is this descending pain inhibiting system. So understand that for all of us, there are some pain pathways which descends down from our brain to the dorsal horn of spinal cord, which actually inhibit pain impulse from transmitting up. Okay, so this is naturally there in our body. So whenever we have mild pain, sometimes or small injury, we may not feel pain at all. So one of the reason would be descending pain inhibiting system. The pain is inhibited. It is not going beyond spinal cord because the descending pain inhibiting system, it reduces the pain. Okay. And another thing is that we give some medications to reduce pain. Somebody told previously morphine, pethidine, etc. So these are opioids. So you know that when you administer opioids externally, or when you give these opioids to take orally or injected into our body, it will reduce pain. So that is known as exogenous opioids. But in our body also produces opioids. That is known as endogenous opioids. Okay, endorphins and enkephalins. These are endogenous opioids. So these can also reduce the pain. So I am talking about how pain impulse is modified. That is known as modulation. One way of modulation is descending pain pathway. Second one is endogenous opioids. And last step is perception of pain. So when the pain impulse reaches the somatosensory area of the cortex, you will feel pain. Okay. So these are the 4 steps involved in nociception. So first step is transduction, in which there is an impulse formation. Then there is transmission. This impulse formed will be transmitted to the somatosensory area of the cortex. Then there is modulation, in which pain impulse is modified, and this modification occurs through descending pain pathway, then endogenous opioids and our emotions. Okay. Then last thing is perception. So with this, I would like you to understand that pain is divided into mainly two types. That is nociceptive pain and neuropathic pain. So when the nociceptor is stimulated, or whenever there is injury to the nociceptor, that can cause nociceptive nociceptive pain. Nociceptors. So where can you see the nociceptors? It is throughout our skin, muscles, bones. So when there is an injury to the skin, muscles, bones, it would be mostly nociceptive. Have you heard of herpes zoster? Anybody heard of herpes zoster?
Yes, sir.
So can you tell me what it is? Explain to
Neuropathic.
us.
Neuropathic pain.
No, what is herpes zoster? Can you please explain it to the group?
It is a viral infection.
Okay, thank you, Dr. Naresh. So, what is herpes zoster? All of you might know about chickenpox, isn't it? And many of you might have also infected with the chickenpox. So, what happens after chickenpox? The chickenpox virus, it gets deactivated. Okay, after the infection, it gets deactivated. Its potency is lost, but it is not going out from our body. What happens to this virus? It will go to the dorsal root ganglion. So please see this. This is the dorsal root ganglion. So these viruses will go and stay within the dorsal root ganglion. Okay. When when our immunity is reduced, this chickenpox virus gets activated, and then it is known as herpes zoster. Okay. So where would be the one of the main symptoms of herpes zoster is severe pain along with some vesicles. So, where would you or where would the patient will have pain? Any idea?
Sir, in
Mm.
axillary region many times.
Okay. Thank you, Dr. Anand. But that is not in axillary region. So whenever the virus, so you can see this is there are many peripheral nerves. So from the cervical region, there are peripheral nerves. Thoracic nerve, there are thoracic peripheral nerves. So what happens is when the virus is in the thoracic 10th peripheral nerve, the vesicles and pain will be there only in the distribution of this nerve. Okay, so thoracic 10th nerve, it supplies to the skin at the level of umbilicus. Okay, so if the patient has affected this 10th thoracic nerve, they will have pain and vesicles only in the skin at the level of umbilicus, just like a belt tied around your abdomen. Okay, that's how neuropathic pain occurs. So neuropathic pain is due to stimulation of peripheral nerve or stimulation of spinal cord or stimulation of brain. That is known as neuropathic pain. Okay. So I want to ask you, suppose a patient comes to you with an injury over the middle finger, tip of the middle finger. What type of pain would it be mostly?
Nociceptive.
Yeah, it would be mainly nociceptive because I told you the nociceptors are mainly seen in the skin, muscles, bones. Okay. A patient with fracture of the tibia, what type of pain it would be?
Hello?
Neuropathic,
Yeah.
Both,
sir.
both nociceptive and neuropathic.
I'm asking mainly what type of pain it would be.
Neuropathic, sir. Neuropathic pain.
No, it would be mostly nociceptive.
Nociceptive.
Yeah, nociceptive. I told you that nociceptors are mainly concentrated in skin, muscles, and bone. So if bone is fractured, the nociceptors are going to get affected mainly. So it would be mainly nociceptive pain.
Alka, Sriprezi, sir.
Yeah.
Alka, will it be possible for you? Sorry, sir. Sorry about that.
Okay. Suppose a patient who comes to you and tell you that I have pain radiating from the back, low back, and it goes down to the foot through the posterior aspect of my leg. It started immediately after lifting a heavy weight. What type of pain it would be?
Neuropathic pain.
Neuropathic.
Yeah, can you
Sciatica
tell me why it is neuropathic pain?
Because the pain travels along the nerves, sir.
Okay, any more explanations?
Maybe due to sciatica pain.
Sorry?
Maybe due to sciatica nerve pain.
So actually what happens when the patient has lifted the weight, the intervertebral disc got prolapsed and it it compressed the peripheral nerve. Okay, and the because of the compression of the peripheral nerve, the patient has pain. So that's why it becomes neuropathic pain. Okay, so just understand pain is mainly divided into nociceptive and neuropathic pain. And now we are moving on to pain evaluation. How would you evaluate pain if a patient is coming to you with severe pain? So important things are you have to take detailed history. So I did not tell you because all of you would be knowing about this. A detailed history need to be taken, including comorbidities of the patient. Maybe many patients with long-term diabetes. I hope you are seeing many patients with the diabetes. So some people will complaining of some type of pain. What would be the usual complaints about pain? Where would it be? And what is the nature of the pain?
Diabetic neuropathy.
Yeah, how would they describe and where would they describe they have pain?
Burning sensation of feet.
Sorry?
Tingling sensation.
Sometimes patient complained about pricking sensation, riddling sensation
Mhm.
at any sides of our body. Sometimes it complains he's feeling somebody is pressing at the local area.
Okay, so mostly the patients with diabetes, if it is long term and uncontrolled, what happens is the peripheral nerves are affected and they usually complains of pain on both hands, especially in this region. Okay, and this is known as and in the foot also. This is known as glove and stocking pain. So they will usually describe it as a burning type of pain. Okay, so when that's the importance of taking history. So from this history itself, you can understand that this patient has a type of neuropathic pain. And then you have to ask specific questions related to pain that will come later, what all we need to ask. Then we also need to explore other symptoms of the patient, not only about pain, but we have to ask what are the other problems you have. And understand what are the psychological problems these patients are facing. What are the social problems? Do they have financial problems? Do they have spiritual suffering? So all this need to be explored. And then we have to examine the patient. And if needed, we have to investigate. So this is how you have to evaluate pain. So I'm I'm now going to talk about what are the specific questions that you need to ask about pain. Anybody know about what we need to ask about pain?
Site and type of pain.
Sorry,
Site and types.
I didn't get you actually.
So
Site,
PQ,
intensity,
RSP of
frequency.
pain, sir.
Yeah, Prakin. So there is a mnemonic by which you can remember what all you need to ask. Okay. So one is location, where exactly the pain is. Okay. Then duration, for how many days you have pain, or sometimes patients may tell you that this pain is there for last 6 months. That means this is a chronic pain. Any pain less than duration less than 3 months can be called as a less than 3 months is called as an acute pain, and more than 3 months is called as chronic pain. So duration of the pain, location, duration, palliative and provocative factors. So there are some factors which can reduce the pain. It might be medication, it might be massage, or provocative factors may be movement, something like that. So you have to ask what reduces pain and what increases pain. That is palliative and provocative factors. Then quality of the pain. So many patients describes pain like burning, throbbing, aching. So you have to ask patients, what type of pain are you experiencing? Is it burning? Is it aching or throbbing? Something like that. That is known as quality of pain. Then we need to ask about radiation of pain. Does the pain travels from the site of pain to any other parts of the body? That is known as radiation of pain. Then what is the severity of the pain? Then you need to ask about temporal factors. Temporal factors means it is time related factors. So many of the patients might tell you that I have pain mostly during night. Whenever I take this tablet, the pain is reduced for 3 hours. So these are all time related factors which can come in temporal factors. Okay, so this is the mnemonic which you need to remember, and you have to ask the patient. Okay, LDPQ RST. In addition to this, you have to also ask what is the effect of pain on activities of daily living. So if the patient is unable to sleep and they are unable to wake up in the morning, they are unable to brush, they are unable to dress, they are unable to eat. These are all activities of daily living. So if they are unable to do this, that means the pain is so severe. Okay. And also find out what's the meaning of the pain. Many patients might tell you, suppose there is a cancer, they might come and tell you that, okay, I have very severe pain and probably this is my end, because their meaning for severe pain is death, okay, or advanced cancer. That may not be the case. So we have to understand what do they mean by pain. Okay, so please keep in mind LDPQ RST. These are the specific questions that you have to ask about pain. So we talked about nociceptive and neuropathic pain. Now, nociceptive pain, I told you that it can happen, or nociceptors are mainly distributed in skin, muscle, and bone. So nociceptive pain is again divided into 2 types. One is visceral pain and the other one is somatic pain. What is visceral pain? Where would be the pain in visceral pain?
Pain is feeling under visceras, like liver, spleen.
Yeah, any pain which arises from inside the abdomen or chest is known as visceral pain. What is somatic pain? Soma means external. Okay. So if the pain arises from the external parts of the body, that is known as somatic pain. So if there is a fracture, that is somatic nociceptive pain. If the patient complains of pain from inside abdomen, that is visceral nociceptive pain. Okay. So just understand nociceptive pain is again divided into visceral pain and somatic pain. If the patient comes with a injury over the left index finger, what type of pain it would be?
Somatic.
Somatic pain.
Somatic
Somatic
nociceptive pain.
nociceptive.
Yeah, very good.
Pain.
Yeah. Now we are moving on to how can we distinguish or how we know this is visceral pain or this is somatic pain or this is neuropathic pain. So what are the features of visceral pain? So visceral pain is poorly localized usually. So a patient who comes to you with abdominal pain, they usually will not be able to point out the pain. Rather, they will just show you the abdomen with their forehand. They will not point like this. Okay. Rather, they will say, okay, pain is here. If it is in the abdomen. So that's known as poorly localized pain. So pain is poorly localized in case of visceral pain. Then usually it is intermittent pain. Pain usually will not be continuous. And they usually say it is a colic in nature or it is like cramps. And sometimes it might be accompanied by nausea and vomiting. So these are the features of visceral pain. What are the features of somatic pain? Usually if there is an injury, we will say, okay, pain is here. So that means it is a precisely localized pain. And usually pain would be constant. So pain is usually constant and there may be guarding or rigidity and movements can increase somatic pain. Okay. So somatic pain, usually it is precisely localized pain and usually the quality of the pain would be throbbing or cutting like aching. So these are the quality of the pain. Neuropathic pain. Neuropathic pain means usually it is neurodermatomal in distribution. That means when there is a peripheral nerve, it will carry sensation from a particular area of our body. So the area supplied by that nerve is known as dermatome. Okay. So when there is an injury to the to a peripheral nerve, that will be having the distribution of a dermatome. So that is usually pain from or neuropathic pain will be neurodermatomal in distribution. That's what is known as that's what is meant by pain carried from a particular area supplied by the particular nerve. Neurodermatomal in distribution. And usually patient will describe the pain as burning, stabbing, lancinating, electric shock like. So these all are features of neuropathic pain. And some patients may complain of abnormal sensations. So abnormal sensation means it can be either reduced sensation or it can be increased sensation. So there is something called allodynia and hyperalgesia. Do you know what is allodynia and hyperalgesia? Suppose a patient takes insulin. It produces mild pain, isn't it? But if the patient complains that today I have more pain compared to the previous pains, that means more than the usual pain. that is known as hyperalgesia. Hyper means more, algesia means pain. So if the pain is more than usual pain, it is known as hyperalgesia. What is allodynia? Allodynia means, I will give you an example. Suppose a patient comes and tell you that I have pain when I touch my hand here in this area. When I touch, I have severe pain. Or when I pour water here, it produces severe pain. So usually touch or water, this will not produce pain. But in this patient's case, this produces pain. That is known as allodynia. So allodynia means the stimulus which usually does not produce pain. When it produces pain, it is called allodynia. And they may also describe some decreased sensation like numbness. So these are the features of neuropathic pain, and this is how you have to distinguish between various types of pain. And now we are moving on to how can we find out the intensity or severity of the pain. Patient may tell, okay, I have severe pain. We have to ask how severe it is. Okay, so there are various types of pain scales used to find out the severity of the pain. So this is one pain scale, which is known as numerical pain rating scale. So there is no pain scale in this to show the patient. This is actually, we tell the patient. How do we tell the patient? You have to tell the patient, right now you told me that you have pain. Now I am telling you a scale to understand the severity of the pain. In that scale, 0 means no pain and 10 means worst imaginable pain. 0 means no pain and 10 means worst imaginable pain. So if that is the case, can you score your pain in the scale? So that's how you have to ask the patient. Patient may tell you 8, 9, 10, 0, 1. So it depends on the patient's perception. So this is how you administer a numerical pain rating scale. There is another thing called visual analog scale, in which you actually show the patient a scale with 2 ends. There is no marking in between. And you tell the patient that this end means there is no pain, and this end means it is worst imaginable pain. Can you mark your pain in this? So they will mark it somewhere on the line. And then the person who assesses this pain, that is you. For you, on the other side of this scale, there are markings from 0 to 100. And you can take the corresponding score to the marked area and you can write it. That is known as visual analog scale. And if the patient does not understand this, you can ask the patient, what is the severity of the pain? Is it mild, moderate, severe, or excruciating? And this is known as non-verbal scales.
Yeah, excuse me.
Yeah.
Sir, VAS scale is only for pediatric use or for anyone?
VAS scale can be used for anybody who can understand properly. Probably children up to the age of maybe up to 7 years, you may not be able to use. And people with the dementia, they may not be able to understand it. So otherwise, a young adult or anybody, you can use VAS. But the usually used one is numerical pain rating scale. Okay. So this is known as Wong-Baker's Facer scale. So in this scale, you can see there are 6 faces. And from this phases itself, you can differentiate how severe the pain would be. And this is used mainly for children in the age of 3 to 7. So you will show this various phases to the child, and you will tell them, okay, this is the phase when you do not have any pain, and this is the phase when you have worst imaginable pain. Can you tell me which out of this, which phase corresponds to your pain now? And they may show you one phase. So that's how this is administered to children who are unable to communicate to us a lot of things about pain. And there is something called a body chart. So you can see here, there are two markings. One is with pink and the other one with the blue. So this indicates that this patient has two types of pain. And you can actually write PQRST and here LDPQRST with each of this pain, so that everyone can understand all the things about pain from this picture itself. And if you are the person sitting in the OPD, and you have, suppose you have written in the case sheet, okay, this patient has pain on the abdomen for the last 6 weeks, and you give some medication, and after 2 weeks, this patient is coming. And now you are not the person in the OPD. It is somebody else. So they are going to review this patient, and when they read this case sheet, it says the patient had pain on the abdomen. Which part of the body or which part of the abdomen this patient had pain, you are not very sure. Patient might tell you previously it was here, and you might be in doubt. So it is important for us to have a body chart like this, so that everybody will understand about pain proper. Now, we understood that patient has either nociceptive pain or neuropathic pain. Now we have to treat the patient. So treatment is with analgesics. And what are the principles of analgesic? Usually, as far as possible, you have to give analgesics by the mouth and by the clock. By the clock means each medication has a duration of action. So according to the duration of action, you have to provide analgesics. So if it is paracetamol, the duration of action is 4 to 6 hours. So you have to give paracetamol at least 6 hours. So that's what known as by the clock. And by the ladder, that means WHO has put forward a WHO analgesic ladder for treating pain. So you have to use the steps of WHO analgesic ladder to give analgesic medication and individualized treatment. So suppose I am taking 10 of you from here, and all of you say that I have a pain score of 7. But if I give you the same medication to all of you, it will not give any relief, or the relief may not be the same, because pain is not only the physical sensation, it also has psychological, or it is affected by many factors. So that's why we have to treat the patient individually. And this is the WHO analgesic ladder. This is put forward by World Health Organization in 1986. And you can see, first step is non-opioid plus or minus adjuvant. And second step, opioids for mild to moderate pain plus or minus non-opioids plus or minus adjuvants. And third step, opioids for moderate to severe pain plus or minus non-opioids plus or minus adjuvant. And what you have to understand is, the first step is used to treat mild pain. Second step is used to treat moderate pain. Third step is for treating severe pain. So if a patient says, I have very severe pain, my pain score is 8 or 9 or 10, that means you have to directly select the medication from the third step of analgesic ladder. So what are the third medications from third step? It is opioids for moderate to severe pain, plus or minus non-opioid, plus or minus adjunct. So just giving you some examples, this will be dealt in detail in the later sessions. Non-opioids, that means medications which are not opioids. This includes paracetamol and NSAIDs. You know NSAIDs, ibuprofen, mefenamic acid, naproxen, celecoxib. There are many things. Adjuvants means these are medications whose primary indication is not pain relief, but it is helpful in some painful condition. That is known as adjuvants. Medications that are medications whose primary indication is not pain relief, but is helpful in some painful condition. So look at here, amitriptyline, which is usually used to treat depression. That is the primary indication, but it is helpful to treat neuropathic pain. So that's why it becomes adjuvant. So mainly there are a lot of adjuvants. I have given only 2-3 groups of medication. One is tricyclic antidepressants. Then the other one is anti-epileptics, sodium valproate, gabapentin, pregabalin. All these are used to treat seizures, but it is helpful in treating neuropathic pain. And then we have opioids. So from the second step onwards of WHO analgesic ladder, we have opioids. In the second step, we have opioids for treating mild to moderate pain. So which are those opioids? Tramadol, tapentadol, codeine, dextropropoxyphene. And in the third step, we have opioids to treat moderate to severe pain, which are morphine, fentanyl, and methadone. Okay. So the young girl, she has severe pain. In addition to those, in addition to the pain, what all we need to address? Can anybody tell me?
The psychological support, others problems are.
Okay, she has, in addition to pain, she has bleeding from the ulcer on the cancer, sleeplessness. She has psychological problems. She has social problems, social isolation, financial problems, spiritual problems. So from where she can get relief for this symptoms? If this young girl goes to a hospital, for what symptoms would be, what type of treatment would she receive? Is she going to receive treatment for her psychological symptoms, social problems? Would any hospitals give some money or food free for this patient? Anybody?
Multi-sectoral approach should be provided to patient, like physiotherapist, like
Okay.
orthopedician, like medicine, like psychologist, doctor, and some aid from government sector also.
Okay, yeah, but I am asking, how many hospitals are giving this type of approach?
Tata Memorial Hospital.
Okay. Any other hospitals? So what I want you to understand is, usually whenever you go to a hospital, the physical problems are addressed, not the psychological, social, financial, or psychological problems. Isn't it? So what we have to understand is, this patient has a lot of problems: physical, psychological, social, financial, spiritual. which together constitute total pain of the patient. Okay, so you have to treat all these domains of suffering to relieve the suffering of this young child. If her mother and child, if her mother and father are separate, what would be the psychological stress that this child is going to undergo? So we have to do something for this. Hospitals usually do not do anything for this, isn't it? And the child would like to stay with both mother and father. We have to actually go and mediate with father and mother. So who would do this? Or this approach is the palliative care approach. Okay. So this is the definition of palliative care. It's an approach that improves the quality of life of patients and their families. Okay. So palliative care is to improve the quality of life of patients, not only patients, their families also. Because if this child is undergoing a lot of suffering, it is she's not the only person who is suffering. Her brother would suffer, her father, mother, and probably their relatives also, isn't it? So that's the importance of caring for the family. So quality of life of patients and their families facing the problems associated with life-threatening illness. So any diseases which reduces the quality of life can be provided palliative care. And how you can improve the quality of life? It is through prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychological, social, and spiritual. So if you address the physical, psychological, social, financial, and spiritual problems of the patient, you can improve the quality of life of patients and families. So this is the definition of palliative care. And I just want to say a few words about history of palliative care. So the modern palliative care, it actually started at this place known as St. Christopher's Hospice in 1967. This is a hospice at UK by this lady, Dr. Dame Cicely Saunders. Okay. So please understand, and this is where the modern palliative care started, and the founder is Dame Cicely Saunders. And if you look at India, it actually not really palliative care, some form of pain treatment that started in 1980s and 1990s in Ahmedabad, Bangalore, and Mumbai, Trivandrum, etc. You have to understand, palliative care is sometimes known as hospice care. Okay, palliative care is used synonymously with hospice. But in America, it is little bit different. Palliative care and hospice care are different. In America, what is hospice care is when the patient has only 6 months to live, they give a special type of treatment or support that is known as hospice care. The care provided to patients who have only 6 months to live. That's known as hospice care in America. But for us in India, hospice care and palliative care are same, because in America, if somebody certifies that this patient has only 6 months to live, then the government will take all the cost of treatment, including providing medicines, caregivers, food, all the expenses would be borne by the government. And the first hospice in India is at Mumbai, which is known as Shanti Avedana Ashram. And this was established by Dr. D'Souza in 1986. And the first community supported palliative care was started in India at Calicut, Kerala, in 1993. Okay. And they had an outpatient clinic and home care services during that time. And this was started by Dr. Rajagopal and his colleagues. And you know, Dr. Rajagopal is known as the father of Indian palliative care. So who needs palliative care? Any patients who has reduced quality of life. Okay, so I am giving a few examples here, but don't misunderstand. These are not the only patients whom we can provide palliative care. There are a lot of patients and lot of diseases in which the quality of life is reduced. So these are just some examples: cancer, stroke, spinal cord injury, neurological damage, old age bedridden patients, Alzheimer's disease, HIV, kidney failure, severe liver failure, heart failure. So all this requires palliative care. And I would like to ask you another question. When should we start palliative care?
From the time of diagnosis.
Okay, very good. So understand that palliative care is not terminal care alone. So previously, palliative care is seen as a care that is provided to patients when the patient is dying. That is not applicable anymore. The palliative care should be provided to any patients when they are diagnosed with life-threatening illness or an illness that can reduce the quality of life. Okay, who should do palliative care? There should be a medical team, isn't it? Because the physical problems like pain or any other physical problems that needs to be assessed and addressed by the medical team, including doctors, nurses, physiotherapists, social workers, and many other peoples. There should be society. What is the role of the society? The society can actually support or can do a lot of things for the patients from the psychological perspective, from the social and financial, spiritual. So psychosocial and spiritual aspect can be taken care by the volunteers in the community. So the care should be delivered by not only by the medical team. We should include volunteers from the community. Okay. So I told you about psychological, spiritual support. And you can see this person is a volunteer. And you can see how the relationship between this elderly lady and the volunteer. So both of them are bonded together. So that is the type of bonding that occurs when we have a true volunteer. So volunteers can do wonders. So whenever you do palliative care, don't ignore volunteers. They are the integral part of palliative care, and they can do a lot in psychological, social, financial, and spiritual aspect. But physical aspect should be dealt by the medical professionals itself. And this is, you can see this patient and look at his hand. This person was a driver, and his bus got into an accident, and he became bedridden. He became quadriplegic. And when we saw him, he was bedridden. And the only demand or what he asked us was, if possible, I should be able to make my earnings by myself. But with a patient who is bedridden, what can be done? So our team of doctors, nurses, physiotherapists, they go to this patient many weekly, and help him with many things. And we were able to make him to sit up. And then the volunteers from that community, they set up a small petty shop. And now he is able to do or able to earn something. There will not be big profit out of this, but still earning by himself. That is very important, isn't it? It is important for us. So these are the types of rehabilitation that can be provided by the community volunteers. And education support for the children of these patients, because otherwise they are going to stop the schooling. And how can we provide palliative care? It can be through outpatient care, or it can be inpatient-based care, and can be home-based care. And home-based care is the most important aspect of palliative care. A team of doctors, nurses, social workers, and volunteers goes together to patient's home and provide the required care at patient's home itself. You can see these are the places from which the patient needs to come to us. It would be very difficult for them. And many of the things which can be done at hospital can be done at patient's house itself. So removing a urine tube and putting a new one, removing Ryle's tube and putting a new one, providing fluid, all this can be done at patient's home itself. And another important thing is empowering the family member is very, very important to take care of the patient. So this patient has a wound which our nurses is cleaning, but we have to also teach one of the family member how to clean and dress this wound. Otherwise, they will not be, or they have to call a nurse or somebody else. So it is very important to teach the caregiver also. So you can see a patient is taken care by his family members. So in summary, we talked about pain and palliative care. So pain, we told that it is not only a physical sensation, it is also an emotional experience. And pain can be divided mainly into two types, nociceptive and neuropathic. Nociceptive pain is again divided into somatic and visceral. And we also talked about various features, or how can we distinguish between visceral, nociceptive and neuropathic pain. And how can we assess pain by LD-PQ-RST? These are the specific questions related to pain. Please remember LD-PQ-RST. Location, duration, palliative and provocative factors, quality of pain, radiation, severity of the pain, temporal factors. Then what is the effect on activities of daily living? And once you find out whether it is nociceptive or neuropathic pain, usually the treatment, the pharmacological treatment is by WHO analgesic ladder. And WHO analgesic ladder, the first step is used for treatment of mild pain. Second step is to treat moderate pain. And third step is used to treat severe pain. And palliative care is symptomatic treatment of the problems. It is not a curative treatment. And in palliative care, we provide total care to the patient and family. Total care means we not only helps to reduce the physical problems, but also psychological, social, financial, and spiritual problems. And it should start at the diagnosis. And palliative care is not a single-handed approach. We should have a team to address the problems of the patient and family. We should include the community volunteers in the care of the patient and family. So I just want to tell you what happened to the young girl that I have shown you at first. Her pain actually got reduced with morphine, and she was able to sleep better. Once her pain is relieved, she actually wanted to get many types of food. Every day she wants various types of food. So which was taken care by the volunteers. And she also wanted to play. So toys, she want toys, which was provided by the volunteers as well as by the caregivers of the other patients. And we talked to the father and mother, and both of them agreed to stay back with the young girl. And after 1 month, we actually discharged this patient, and after a week, she died. But after 3 months, we actually inquired. Our volunteers actually was there who got involved with the parents, and we were able to make sure that the brother of this patient, he was admitted into special school, and husband and wife are living together, and husband stopped alcoholism. He is not taking alcohol anymore, and mother was provided with a tailoring machine, and which she was an expert in tailoring. So the volunteers could make it. So this is what I am telling. Volunteers can actually do wonders. And now the family, even though the girl is died, the family is happy. Okay, so with this, I think I will stop here. If you have any doubts, you can ask.
Excuse me, sir. Hello. Hello.
So your voice is very feeble, I guess, or is it only for me?
अब आ रही है मैम आवाज?
थोड़ी धीमी है सर, थोड़ा और अगर आप माइक्रोफोन यूज कर रहे
ना
हो।
मेरा एक क्वेश्चन था, जो प्री असेसमेंट टेस्ट था ना, उसमें एक क्वेश्चन था कि व्हाट विल बी द ब्रेक थ्रू डोज, रेस्क्यू डोज ऑफ मॉर्फिन। तो उसमें जो मॉर्फिन की डोज थी, रेस्क्यू डोज थी, वो क्या होनी चाहिए? जैसे उसमें 10 mg वो क्वार्टरली ले रहा है ऑलरेडी, तो उसकी आगे क्या डोज होनी चाहिए?
Sunil sir, were you able to get the question?
No, I am unable to understand it properly.
What will be the rescue dose of morphine when patient is already taking 10 mg quarterly 4 times a day? Sorry, 4 times a day or quarterly? There was a question in the pre-assessment test that what will be the rescue or breakthrough dose of morphine when patient is
Okay, I understood. Thank you, Dr. Devesh. I think we have a session on opioids in which this will be dealt. But for as of now, whatever be the normal dose of morphine, that is given as the SOS dose. So if somebody is taking 10 milligram 4 hourly, that means 10 milligram is the SOS dose.
Okay. Okay.
Sir, please provide PPT.
Yeah, that step I will provide.
Any other pressing questions, queries we can take in? Thank you so much, Dr. Sunil, for joining us on this wonderful evening and providing us with the introduction of palliative care and pain. Before logging out, I just want to convey some important points. So please be patient with us.